As you can see on this graph, an example from modeling study very clearly showing linear dependence between incarceration rates in former Soviet Union countries and tuberculosis incidence rates in general population. All these factors create a perfect storm of comorbidities, co-infections, and co-epidemics of tuberculosis, including multi-drug-resistant tuberculosis, HIV, hepatitis C, and injection drug use. So that was a short introduction into epidemiology and the perfect storm of all co-infections and comorbidities. And now we will move further to discuss on how we manage these comorbidities. And here is a very important terminology is a continuum of care. Continuum of care describes the successive steps in healthcare required for individuals to go through in order to achieve optimal healthcare outcomes. The HIV continuum has become an integral public health tool for evaluating the outcome of HIV programs, from diagnosis to linkage to care, initiation of antiretroviral therapy, and virological suppression. It is very well known under the 90-90-90 goal, and here we need to ensure diagnosis of HIV, treatment with antiretroviral therapy, and which is very, very important, retention in care. Management of all three conditions should start with integrated care. It is a key to successful management. It should be patient-centered, and continuous dialogue between treating specialists should be ensured. All TB patients should be tested for HIV and viral hepatitis and vice versa. So all HIV patients should be evaluated for tuberculosis in high endemic areas and also be tested for viral hepatitis. It is very important to establish a correct diagnosis. It is especially true for tuberculosis, and especially where we don't have bacteriological confirmation and thinking about presumptive tuberculosis. And also we need to ensure treatment. It varies, of course. The most important aspect of management of all three conditions is integrated care. It is a key to successful management. It should be patient-centered, and we should ensure continuous dialogue between treating specialists. All TB patients should be tested for HIV and viral hepatitis, and vice versa. So all HIV patients should be evaluated for tuberculosis, especially in high endemic areas, and also should be tested for viral hepatitis. We need to make sure that we are giving patients a correct diagnosis. This is particularly true for tuberculosis, especially if we don't have or cannot achieve laboratory confirmation and considering presumptive TB diagnosis. And also we should ensure treatment of all three conditions, and it of course varies. For HIV infection, it is a lifelong treatment. For hepatitis C, it is now only for 8 to 12 weeks. And for tuberculosis, as we very well know, it can be between 6 and up to 24 months, depending on type of tuberculosis. For treatment of tuberculosis, it is very important to ensure drug susceptibility testing and resistance profile of Mycobacterium tuberculosis, to ensure directly observed therapy. Also, we need to ensure close monitoring of treatment efficacy and side effects. After we have treated these infections, we need to ensure correct follow-up. This is especially important for HIV because it is lifelong. It is also important for tuberculosis. as we need to ensure that there is no relapse of TB, and we need to ensure a sustainable virological response for hepatitis C. We also need to ensure treatment of other conditions, as well as providing patients social support and psychological support. So now moving further to management of HIV infection, it is very well described and outlined in WHO guidelines, and in 2019 they've been released an update to recommendations, particularly covering dolutegravir treatment and lower doses of efavirenz. All people living with HIV should start antiretroviral therapy as soon as possible after HIV diagnosis was established, and dolutegravir is currently recommended as a first-line antiretroviral regimen in combination with an RTI backbone. As an alternative for first-line ART, efavirenz can be used, and lower doses is recommended. For second line, we need to primarily optimize an RTI backbone and can continue dolutegravir, or boosted protease inhibitors in combination with an RTI backbone can also be used. Timing of ART initiation for people living with HIV and tuberculosis has now been addressed, and it is highly recommended that ART should be started in all TB patients, including those with MDR and XDR TB, regardless of CD4 cell count, and as soon as possible. TB treatment should be initiated first, followed by antiretroviral therapy as soon as possible, and within the first 8 weeks of treatment, if CD4 cell count over 50 cells per microliter. It is allowed a delay for 8 weeks or maybe even longer if there are any concerns about drug-drug interactions or side effects or tolerability. HIV-positive patients with profound immunosuppression, meaning CD4 cell count under 50 cells per microliter, should receive antiretroviral therapy within the first 2 weeks of initiation of TB treatment. This is also true for patients with meningitis, but we need to consider immune reconstitution syndrome and remember about it, and I will talk about it within the next slide. The recommended antiretroviral therapy for HIV-TB infected people is dolutegravir based in combination with TDF and 3TC. But remember, we need to increase dose of dolutegravir to 50 milligrams twice daily due to drug-drug interactions with rifampicin. And efavirenz of 400 milligram can be co-administered with rifampicin containing TB treatment. There is a possibility for other ART drug combinations together with rifampicin and also with rifabutin, depending on tolerability, side effects, and other drugs patients is using, and you can look up for these drug combinations in guidelines if needed. When treating TB, including drug-resistant TB in people living with HIV, we need to carefully review all drug interactions and potential toxicities before initiating therapy. And this is due to the fact that rifampicin is known for its drug-drug interactions due to its metabolism. Detailed information on DDIs can be found on the University of Liverpool website, and examples are shown here, and it is very handy website to use. So I would recommend, if you are in doubt of any drug combinations with HIV drugs, so you just visit this site and figure it out. When we talk about management of tuberculosis in people living with HIV, it is very important to remember about immune reconstitution syndrome, or IRIS. IRIS can be presented in two forms, paradoxical and unmasking. Paradoxical is worsening symptoms during antiretroviral-induced immune reconstitution period in association with inflammatory signs after exclusion of the expected cause of treated or untreated opportunistic infection or drug toxicities. Or unmasking IRIS is defined as a new onset of symptoms during ART-induced immune reconstitution period in association with inflammation signs after exclusion of the expected cause of treated or untreated underlying disease or drug toxicities. There is a possibility to prevent paradoxical TB IRIS by prophylactic treatment with prednisolone for 4 weeks at the time of ART initiation in patients with CD4 cell count below 100 cells and also receiving anti-TB treatment. Also, corticosteroids should be considered for treatment of symptomatic IRIS, with dosage and duration tailored according to response. Now moving further to management of hepatitis C, and as basis for this we have guidelines from WHO on treatment of persons diagnosed with. Now moving further to management of hepatitis C. Globally, an estimated 71 million of people have chronic hepatitis C. 1.75 million of new infections per year is registered, and 400,000 deaths due to hepatitis C per year occur, and there is no vaccine for this infection. But there is an effective preventive measures, as for example screening of blood transfusion, needle exchange programs, and so on. And there is also effective treatment with direct-acting antivirals or DDIs, with cure rate over 95% became available since 2014. WHO had developed 2030 elimination goals for hepatitis B and hepatitis C, and it includes the following: reduction in new infections by 90% in 2030 compared with 2015, diagnosing 90% of chronic hepatitis infections, 80% treatment coverage among eligible individuals with chronic hepatitis C, and reduction in mortality caused by viral hepatitis by 65%. The following continuum of care for hepatitis C was proposed and comprises 7 steps, 4 of which are key steps and 3 are supplementary steps, and it's starting from estimation of hepatitis C prevalence and getting diagnosed as many cases as possible to started on treatment and achievement of a sustainable virological response. On this slide, you can see that a much smaller proportion of HCV antibody-positive persons in Eastern Europe got ever tested for HCV RNA, only approximately 50%, and proportion of ever HCV RNA-positive individuals who completed treatment ranged from approximately 50% in Southern Europe to approximately 30% in Central, Eastern, and Eastern Europe. So what should we treat hepatitis C with? Currently, WHO recommends the use of pangenotypic DDIs for treatment of persons with chronic hepatitis C infection aged over 18 years. Here you can see examples of regimens. Primarily it is sofosbuvir with velpatasvir for 12 weeks, but also other regimens are possible. During management of patients with hepatitis C and tuberculosis co-infections, we need to remember about close monitoring of these patients and regular laboratory measurements of liver function, as it is very well documented that hepatitis C infection increases hepatitis risk during anti-TB treatment. So it was shown that even with normal baseline liver biochemistry tests, HCV infection had a higher incidence and longer exacerbation of hepatitis during anti-tuberculosis treatment. Therefore, it is very important, firstly, to ensure that all TB patients, when starting anti-TB treatment, have been tested for hepatitis C, and also to ensure continuous monitoring of their liver function. This study from Armenia and Georgia evaluated bedaquiline treatment and possibility to give it longer than 6 months. And it documented that hepatitis C and HIV co-infection were significant risk factors for unfavorable treatment outcomes among patients receiving bedaquiline at treatment start. Moving further to management of tuberculosis, and here you can see an overview of the main WHO documents currently available. As you have all this workshop dedicated to the management of tuberculosis, I will not go too deep into details. The only thing I would like to stop by and discuss with you is the management of drug-resistant tuberculosis. You can see current guidelines on this slide. It's been implemented in 2019 and improved in 2020. And thanks to two novel drugs, bedaquiline and delamanid, it is now possible to provide patients with all per-oral regimens, which makes treatment much more easy. As I just mentioned, there are two already approved drugs for management of drug-resistant tuberculosis, and a third drug, pretonamid, has also been recently approved. It was evaluated in the NICS-TB study as a part of so-called B-PAL drug combination consisting of bedaquiline, pretonamid, and linezolid. People with XDR TB as well as treatment intolerant or non-responsive MDR TB were included in this study, and successful outcome was reached in 95 of the first 107 patients after 6 months of treatment with B-PAL regimen and 6 months of post-treatment follow-up. The next few slides are dedicated to side effects, and of course there are several of those. One of the most important ones is liver toxicity, which I already mentioned when discussing hepatitis C treatment. The next side effect, which I think is also very important, is prolongation of QT interval. So what is QT interval? It is a measurement made on ECG from the start of Q wave to the end of T wave, and reflects time taken from when cardiac ventricles start to contract to when they finish relaxing. An abnormally long or abnormally short QT interval is associated with an increased risk of developing abnormal heart rhythm and sudden cardiac death. Prolongation of QT interval can increase a patient's risk of developing of so-called torsades step pointers, which is a specific type of abnormal heart rhythm or polymorphic ventricular tachycardia that can lead to a sudden cardiac death. See, and now you will see why it is important to talk about QTc prolongation and remember about it when we talk about management of tuberculosis, hepatitis, HIV infection, and also other opportunistic infections in HIV positive population. See how many drugs can cause QTc prolongation. Antibiotics, and among those ciprofloxacin, levofloxacin, ofloxacin, all drugs that we use for treatment of drug-resistant TB. Antiretrovirals can contribute to this. Antifungal drugs can contribute to this. Patients might have comorbidities and might be treated with other drugs that contribute to QTc prolongation, such as antidepressant and antiarrhythmic drugs. And this list is actually much longer. This study from 2013 established some risk factors that contribute to QTc prolongation and thus development of TDP. And it is, first of all, electrolyte disbalance such as hypokalemia, hypomagnesemia, and hypocalcemia, but also heart failure and also increased plasma concentrations of respective drugs. So please remember these factors and ensure its assessment when initiating treatment, but also during the treatment. Analysis of 144 published articles describing 249 patients with drug-induced TDP had shown that nearly 100% of patients had at least one risk factor for TDP development, and 71% had at least two risk factors. I would also like to mention that some drugs known to cause TDP require dose adjustment in patients with acute and chronic kidney injuries. And this is first of all fluoroquinolones, levofloxacin, ciprofloxacin, and also fluconazole and a number of other drugs. Next chapter is dedicated to drug-drug interactions. And here, of course, we talk first of all about drug-drug interactions between anti-TB, anti-HIV, and anti-HCV drugs. So on this table, you can see elimination of anti-tuberculosis drugs and their effects on enzyme and transporter activity. First of all, we should look on rifampicin, rifabutin, rifampicin. Because to a great extent rifamycins are eliminated by intestinal and hepatic metabolism with involvement of cytochrome system. Then isoniazid is extensively metabolized mainly in the liver. Many of second-line anti-TB drugs appear to be metabolized by other non-cytochrome routes and thus are not affected by cytochrome inducers or inhibitors, and that's why there are less drug-drug interactions expected overall for second-line anti-TB drugs. Beta-2-quilin is eliminated hepatically, being betamolyzed predominantly by cytochrome 3A4, and delamanid has a unique metabolic pathway. It is first metabolized by plasma albumin and then further metabolized by cytochrome enzymes through multiple metabolic pathways. So why it's all important to know about anti-TB drugs? If you look on the next table describing elimination of DDAs for hepatitis C and their effects on enzymes and transporter activity, you can see here that even though the route and extent of metabolism is varied among DAs, many of them are also metabolized through cytochrome system. Common metabolic pathways lead to drug-drug interactions, and on this table you can see interactions between drug-susceptible TB and hepatitis C drugs. As you can see here, rifampicin and rifampicin are no-go with most of hepatitis C drugs. So here we have a major challenge. It looks better with second-line anti-TB drugs, and there are much more possibilities here for co-administration, both anti-hepatitis C drugs and second-line anti-TB drugs. This table here presents drug-drug interactions between antiretrovirals and direct-acting antivirals for hepatitis C. But if you would like to know more or evaluate any other drugs, I would recommend you visit HIV and HCV drug interactions website, and I will provide links for you at the end of this presentation. Moving to summary and conclusions of my presentation, I would like to underline that management of TB, HIV, and HCV infections is complex and require considerations of many aspects, medical as well as social and also psychological. Simultaneous treatment of all three conditions is possible but require careful evaluation of each and particular case, and also then careful monitoring. People-oriented multidisciplinary care team should intend on management of multiple conditions. Remember the main principles of medicine: treat a patient, not a disease, and do no harm. We need to ensure identification of needs of a patient and deliver them to patient. We need to ensure active monitoring of during treatment, including drug safety monitoring and also management of side effects and drug-drug interactions. And we need to integrate not only healthcare per se, but also healthcare need to be integrated with social and psychological care. Continuum of care is the key to successful management of our patients. It ensures retentions of patients in treatment and care, then improvement of continuum of care and will also improve outcomes of patients. And also when we are talking about patients within prisons, we need to secure a good transfer from prisons into the society. Appropriate information, education, early case detection, and thus treatment will result in infection control and stop spread of TB and drug-resistant TB and HIV infection, and also hepatitis C. If you have dedicated staff on all levels willing to collaborate with each other, this is the right way to success. And I should also mention that there is no success without political will and commitment. If I should summarize particularly on problems within prisons, namely on management of TB, HIV, and HCV co-infections, I would like to mention that prevalence of all three diseases is very high in prison settings, including very high levels of drug-resistant TB, including extensively drug-resistant tuberculosis. And there is a need to develop cost-effective interventions to diagnose, treat, and prevent transmission among incarcerated population. Strategies for improvement can include integrated patient-centered, care and prevention. It will include systemic screening, intensified case finding, including contacts, improvement of diagnostic facilities, including availability of rapid tests, collaborative TB, HIV, HCV activities, and management also of other comorbidities, and also preventing treatment of patients at high risk. Then bold policies and supportive systems should ensure improvement of political commitment and high prioritization of TB in prisons, engagement of communities, civil societies, and public health organizations, also ensuring infection control. And intensified research and innovation to better understand health situation in prisons and identify ways to improve it should also be implemented. Here I included some useful links for your information. The first link is where you can find more information about drugs contributing to QT prolongation. Then Liverpool University drug interactions sites for HIV and hepatitis C. I also allow myself to include the link here to EACS, European AIDS Clinical Society guidelines, which is very much consistent with WHO guidelines, but developed in a form of pocket guide. And also here a link on online course on clinical management of HIV, which was developed in collaboration between WHO and EACS. I would like to thank you all for your attention and for possibility to be here with you today and provide with this presentation. I hope it was useful. I apologize that I cannot be live online with you today, as I'm also on duty at my department and managing COVID patients at the moment, but I will join you tomorrow for the session where you will have an opportunity to ask me any questions. Thank you very much.
Большое спасибо, Фахрия Ханум, за то, что вы продемонстрировали нам презентацию и выступление доктора Подлекаревой. Коллеги, в связи с тем, что ее сейчас с нами нету, и как она сама сказала, давайте прибережем наши вопросы до завтра, просуммируем, и когда она к нам присоединится, мы тогда ей их и зададим. Хорошо? Если есть какие-то моменты и замечания, пожелания насчет сегодняшнего дня, мы на 20 минут превысили ожидаемое время окончания сегодняшней части семинара. Дайте мне знать, пожалуйста, есть ли какие-то замечания, комментарии, вопросы. Если нету, тогда я попросил бы всех завтра присоединиться, как обычно, как и сегодня, где-то минут за 15-20 до начала непосредственно вебинара. А так, всем хорошего дня, спасибо большое, всем будьте здоровы. Берегите себя. Я останавливаю запись.
До свидания. Спасибо, начинаем. До завтра.
До свидания, счастливо всем.
До свидания, всем пока, до завтра.
Спасибо.
Спасибо.
Счастливо.